All right, lovely. I'm going to start then. Hi, everybody. Thank you very much, Sarah, for inviting me to speak today. I really want to tell you about what happened in March when, as a team at the Evelina, we had the privilege of working over a period where we were able to describe a new disease in children, obviously a once-in-a-lifetime opportunity for many of us, and really to tell you a little bit about that, that disease. So I will, when my keyboard works, I will tell you what happened over the next 45 minutes ago by just really understanding what the scene was, what the scenario was when we started, and a little bit about the children that we saw. So as you all know, in December last year, we started hearing stories or news from China, from Wuhan, about a new coronavirus being transmitted from a probable bat vector in food markets in China, infecting humans. And obviously at that point in time, it didn't really appear to be that much of a concern for most of us because we don't have food markets selling bats in England, and so it didn't really seem that threatening. But very quickly, over the next few months, we saw it spread rapidly across China and across Asia and then into Europe. And by March, it was affecting our close northern European countries, including Spain and Italy, and they were really in quite significant trouble. But for pediatrics, it really didn't seem to be too much of a problem. And certainly we had information from Wuhan that although there were significant numbers of people affected, the majority of those were not children. If they were children, they were slightly older children. And if they were affected at all, they were not severely affected. So it didn't really seem that bad for us. So we continued living our normal lives, really, obviously watching things with some concern in Europe, but we were able to still go away on holiday. We were able to participate in mass sporting events in London towards the end of February. And in March, we were happy to see the daffodils come out, and nothing was really that bad. And then by the middle of March, we really could see that actually this was going to be a significant problem. Even if it wasn't going to be a problem for children, it was going to affect us in the way that actually it would affect our families, our colleagues, and so this had to be taken extremely seriously. And obviously, early in the middle of March, we saw the first kind of patients being admitted to our intensive care units, obviously treated as highly contagious infectious diseases. We saw people go completely mad with emptying shelves around us and starting to hoard, and we saw London empty completely with lockdown. And the world we once knew was no more for a while. And at the same time, we also saw our adult intensive cares reaching in our own hospitals, which had expanded the number of sites that they were working out of. And certainly in our hospitals, this is St. Thomas's, they had moved into multiple locations and wards, which they had upgraded to intensive care units. And we saw them reaching capacity in many of these units. But obviously at that time, it was still, for us in pediatrics, although our adult colleagues were really taking strain, it was still a nice journey, at least for us home. From a pediatric point of view, we were much quieter than retrieval services. By that time, in the middle of March, all the pediatric intensive care units in South London, at King's and George's, and ourselves at Evelina had emptied out of our usual pediatric in intensive care units, and we had given those up to our adult colleagues. So our lovely 20-bedded pediatric intensive care unit had actually become a facility for 40 adult intensive care beds. As you can see them all piled here, double pendanted in our one space for each child. And at the same time, lots of our nurses, who were also employed to work in the adult intensive care, which had been relocated into our pediatric intensive care, were also being requisitioned really to go and work at the Excel Centre to open more capacity for adult intensive care. But really for pediatrics, it hadn't really become a major problem in that there weren't lots of critically ill children yet. And then in the middle of April, we had a big 14-year-old child who was referred via STRS from one of our district general hospitals, who had a history of 4 days of temperatures and headache, and then 3 days of quite significant loose stools and vomiting. And he was referred because despite being on antibiotics at the DGH, he was persistently tachycardic and tachypneic, and had, despite being on appropriate antibiotics or what they thought were appropriate, had worsening inflammatory markers and was developing acute kidney injury. And by the time he was referred, he'd already been resuscitated with 1.5 liters of fluid boluses for hypotension and started on some dopamine. And on the X-ray, they'd also noted some cardiomegaly. So he was retrieved by STRS to the Evelina. And this child was very unwell with refractory arrhythmias, both to medical and electrical cardioversion. He had progressive shock despite very, very significant doses of Presols, and eventually landed up on VA ECMO. At the time that he went on VA ECMO, he had already been started on steroids because of vasopressor unresponsive shock. And over the next few days on VA ECMO, we were able to obviously rest his heart, and he very quickly weaned off the Presols to the point that actually he was able to be weaned off ECMO. But unfortunately, despite being weaned off ECMO, he did not regain consciousness at all. And after an MRI, we were able to determine that he'd had a massive left MCA infarct, which progressed to brain death, and he died. And then, very concerningly, over the next day, we had 2 children from exactly the same borough as this child who that I've just described, who'd been on ECMO. And then 2 days later, on the next day, so 2 days after the initial child had been admitted, we had 2 more children, one more from this exact same borough, and then another child from not far away. And so all these children really were from, or 4 of the 5 first children were from the same London borough. And we obviously started worrying that there was something local, were they going to the same church or school? But obviously they were all locked down, and they'd been very good about keeping isolated their families. We looked at perhaps it was food delivery. We found that there was a sewage farm very near most of their houses. So with that in mind, we were very concerned, that there was something going on in that borough. So that was one concern, but we were also aware that in that region, in that area in London, they'd had very, very high numbers of adult patients with coronavirus. And we thought, well, this has just got to be too coincidental. So was this something related to coronavirus? So we put out a public health alert. And why we put out the public health alert was because in our intensive care, we have lots of fellows from Europe. And when we saw our 5 children who all had very, very similar clinical picture, which I will describe in a few minutes, when our fellows were communicating with their colleagues in Spain and Italy, the Spanish and Italians had been seeing exactly the same things which they had identified as Kawasaki, but these children were not our typical Kawasaki, and I'll talk a little bit about that in a minute. So with that in mind, we spoke to Public Health England, and we suggested that actually this was something most likely related to coronavirus. It wasn't typical Kawasaki. It was a mixture of other clinical patterns that we see. And Public Health England, and obviously we'd had 1 death already, and Public Health England took that very seriously, and they sent out an urgent alert to general practitioners and some of the other pediatric intensive care units in England. Unfortunately, the way that information dissemination was managed was not entirely perfect, and very quickly we had the press all over this, warning us that there was this cluster of children with this hyperinflammatory kind of condition in southeast London, and obviously there was the child who had died, including this fatal, as you can see in this press report. So that was unfortunate, but that allowed us to very, very quickly escalate via the Royal College of Pediatrics to dissemination to all pediatricians and all pediatric intensive care units that actually we had this inflammatory condition probably relates to coronavirus. All the families in our the first cohort had all had symptomatic adults in their houses, although the children had been completely asymptomatic, and so we thought it probably was related to coronavirus. So the RCPCH developed this guidance in a short period of time, and as the RCPCH guidance went out, we published this case report, well, not case report, this letter really, describing the first 8 children over the period of 3 or 4 days. By the time this case report went out, we had already had 16 within sort of 10 days. And so as soon as this case report was published in the Lancet, it obviously kind of went international. In England, there were certainly people who were, especially, in sort of northern England, who the coronavirus wave hadn't really hit northern England as hard as it had hit London yet. And so we had lots of people not believing that this was a real thing and that we were just exaggerating. And this was probably just Kawasaki. But as soon as the Americans saw the Lancet report, they started seeing or admitting that they were seeing exactly the same kind of children, and they had some children die exactly as we had, with a combination of kind of Kawasaki and toxic shock. And that letter kind of instigated this international webinar where by the end of the second week after we admitted our first, which was actually the patient that we thought was our index case, was actually, when we looked back, our second child. We were able to have this very big international webinar from America to China with over 900 people attending and all sharing experience, which I don't think we really, before coronavirus, had really had this kind of mechanism to share international collaboration as well as we did here. So really, that was how these happened, and we can talk about it afterwards in questions. But obviously what we were seeing was a new clinical syndrome, which had lots of similarities to other things we're more familiar with, but it didn't fit into anything specifically. So I've put up the things that we were kind of looking at when we saw these children. So none of them were typical Kawasaki, although they did have clinical features and laboratory findings in keeping with Kawasaki. None of them were typical secondary HLH, although they did have the hyperferritinemia of the secondary HLH. And none of them were really pure toxic shock either, although they did have the rash and the GI symptoms. Lots of them were shocked, as I'll explain to you later. Most of them actually had very elevated CRPs and very deranged biochemistry and hematology and coagulation parameters. So really it was something that was kind of crossing all these 3 clinical spectrum as a clinical overlap syndrome. And so unfortunately, it got this very long-winded name, which we've shortened down to PIMSTS, Pediatric Inflammatory Multisystem Disorder temporarily associated with the SARS-CoV-2. And that obviously has quite a distinct pattern of disease with a very significant spectrum of severity, from the milder version to the very severe children and even fatal cases. So these children were typically older boys in the kind of with a median age of around about 11, across the world either 9 or 11, but not the sort of the Kawasaki age. And very interestingly, from our first group of 16 children, which this is the group that we had got to by the time we published that letter, they were majority Afro-Caribbean with another significant proportion who were Asian, but there were very few Caucasian children in the first group. And that obviously mirrored what we'd been seeing in critically ill adults, but was very different to the ethnic mix that we see in London. So we thought there must be something related to their ethnicity, and we can talk about that in a minute. And so you can see from this that there is this big kind of over-representation of Afro-Caribbean children in the PIMSTS group, and that has been mirrored across the world. So what did these children look like? They had signs of systemic inflammation. They had significant fever, I mean really significant fever, which was difficult to control. And they had kind of a variable rash. They had a peripheral edema as they arrived in ICU, even without any significant fluid resuscitation. And some of them had, related to the edema, had kind of desquamation after the rash kind of defervesced. And they had a history leading up to the presentation of lethargy, although most of them were previously completely well children with very, very few or minimal comorbidities. The majority of them had very little respiratory involvement. They symptomatically, they didn't have very much, and very few of them required any significant respiratory support across the UK publications that have come out so far, and across the international publications. Cardiac was a very significantly affected system, and they presented with multiple variable arrhythmias. As you can see, this is one of the children, the monitor of one of the children, both atrial, nodal, and ventricular arrhythmias. Lots of them had very significantly reduced cardiac function. A large proportion of them had some degree of valve regurg or valve dysfunction. We had a significant proportion on inotropes for shock, and that shock, the thing that was notable about the shock was that they did not respond well because of the cardiac dysfunction to large volume resuscitation as they normally would in toxic shock. So toxic shock can have 200 mils per kilogram and still be very volume responsive. These children did not do well with large volume resuscitation, which we discovered early on. And then very worryingly, there was also a significant number of them that had coronary artery abnormalities, including very significant aneurysmal dilatation. And one of the children across the country had a little child actually had a ruptured cardiac aneurysm and died of that. And then they also, as part of their abnormal biochemistry, had elevated cardiac enzymes. And there were a very, very, very small proportion who were unresponsive to our normal treatment. And these were the ones that were early on, before we realized how we had to manage this disease, which we'll talk about in a minute. The other things that the cardiologists were able to detect very early on, that the coronaries were very prominent. You can see they're very bright, the walls of the coronaries are very bright on these echo images, and you can see that in the bottom left picture, echo picture, there's the beginnings of sort of coronary artery ectasia. So not actually a kind of a significant aneurysm yet, but just an abnormal kind of not completely smooth coronary wall. And then some of those children, if they weren't managed very early on, they progressed to giant coronary aneurysm, including the one child that I described to you who died, not in our unit, but who died in one of the other units. The other really significant part of the presentation was diarrhea and vomiting. When I say diarrhea, this was not kind of rotavirus or norovirus diarrhea where you've got kind of watery stools. This was children with kind of loose stools, not huge amounts per day, but actually a significant problem, and also very significant abdominal pain, to the point that actually a number of children, and this is just one paper from GOS reporting 8 children who'd been operated for atypical appendicitis, but there were other children across the country that were, and we had some too, who'd been operated as appendicitis because of the significance of the abdominal presentation, and in fact had negative appendicectomies, although the appendix was obviously removed, but they had normal appendix on microscopy. And so we very quickly made sure that our surgical teams realized that if they got these children with a significant history that fitted in like this, they should make sure that they do the right investigations to exclude the kind of PIMSTS group presenting like this. Renal involvement was not a major issue in the majority of children, and it was really isolated to those children who were the sicker children in ICU with multi-organ involvement, but none of those children went on to receive renal replacement therapy in the British cohort. The other important disease kind of spectrum was neurologic involvement, and we obviously had seen that in the adults as well, with strokes in the adults. And these are the various clinical presentations that we have seen described in children related to coronavirus. So both neuropathies and encephalopathies, myelitis, looking at it in a kind of a post-infectious or para-infectious kind of spectrum. And the children that are most likely to get the neurologic complications and do worse with the neurologic involvement are the children with the higher levels of inflammatory markers. So those are the kind of group to target in terms of your neurologic surveillance. So what were those laboratory findings that were abnormal? Well, the striking features were really the lymphopenia was almost universal, which obviously is not unusual in viral diseases. Thrombocytopenia was also very significant. They all were hyperferritinemic, as you would get in HLH, and a lot of them at the very beginning had elevated D-dimers. The CRP was, some of them presented with incredibly high CRP, sort of in the 400 to 500 range, which obviously is very unusual in viral or post-viral infections. And then also very unusual in viral related infections, as many of them had very, very elevated PCTs, which we normally see in bacterial infection. And then there was, as I said before, there were a lot of the children who had abnormal cardiac enzymes, but unfortunately, the cardiac enzyme abnormality was not the sole discriminator for the children who would go on to develop cardiac coronary aneurysm abnormalities. And very early on, we realized that this was an inflammatory process we had to get in control of. So from the very, very beginning of our cohort, we started measuring interleukins and other cytokines. And as you can see in this, they're very, very elevated. And as I alluded to previously, because we noticed that there was this predilection for Afro-Caribbean and Asian children, we decided to look at that more carefully. We started measuring vitamin D in all those children, and we noticed that the vitamin D was very, very low in all of our children being admitted. And obviously, these children had been, gone through winter in London and then locked down for, for 6 weeks at least before they're presented. So reason to have low vitamin D levels, and obviously vitamin D is also suppressed in acute inflammation anyway. So what role that plays, we don't know. So having recognized the pattern of disease, we also very quickly worked out how to treat them. And how we worked that out really was in our first child. When we looked back on that first child who died after the ECMO run, we realized that actually the turnaround came as soon as he was started on steroids. And so we started looking very carefully at was this a group of children who actually just needed to control inflammation? And that has progressed in the UK very, very nicely to now a kind of consensus management pathway for these children with 3 focus groups looking at, special investigations in order to help you identify these children, because they are this crossover group and you can get them wrong. They look very much like normal sepsis in many instances. There's a sort of a management process because obviously lots of them have cardiac involvement, so not all the PICUs have cardiac, and not all the the tertiary hospitals have cardiac surgery or ECMO capability. So which ones do you put into an ECMO center and which ones do you not? And then obviously what is their clinical therapeutic management. So we've got a very nice consensus paper recently published in the Lancet. So the current treatment, I think the focus really is on a very high level of suspicion for these children, although obviously it's a kind of an overlap disease with lots of common features for other things that are much more common for us. You've got to just recognize the illness or the possibility of having the illness, and then very importantly, you must identify and manage the shock. And as I said before, these children do not respond well to large volume shock resuscitation. So getting in early tertiary support from the retrieval services and managing the shock with inotropes rather than just with volume. and then ensuring that you've undertaken the baseline investigation so you know what you're dealing with, and then start to control the inflammation. And what that inflammatory control looks like, and we've now got sort of meta-analyses looking at the best treatment, is starting with kind of the first line of treatment with immunoglobulins, aspirin and steroids, and then if you don't get a good response over 48 hours for your first line inflammation control, then progressing to biological modification. And luckily, we were very, very lucky to have in our unit Michael Carter, who's one of our research fellows in PICU, linked to KCL, and he was able to join a study which was already in progress and immunophenotype these children. So they were all the first children were signed up to this immunophenotyping. And what he has kind of described in his paper in Nature is 3 phases of illness that you can see based on the cytokine levels. The first 3 days of critical illness until you start to get kind of inflammation control, and then a stage of clinical improvement and resolution, as well as resolution in the cytokine values, and then your kind of more prolonged convalescence over the next few weeks. And in his paper, he was able to kind of show the rationale for using the different biologics, because there were lots of different units using different biologics. But as you can see from this slide, you had your IL-6 and your IL-1 very elevated. So tocilizumab targeting IL-6 blockade, and infliximab targeting tumor necrosis factor almost in the same way that you would with Kawasaki, and then the IL-1 slightly lower numbers, but obviously in those group, and those were kind of usually the littler children, sometimes anakinra was used. So where are we now? We really have gone at unbelievable speed. I think you'll all agree, from those first cases that we recognized in April to international kind of consensus and international description and agreed kind of management, or at least suggested management pathways for these children, and a huge amount of international collaboration in big, big kind of multi-center trials. And part of those multi-center trials are ongoing in the UK in both adults and children, looking at the best available treatment and looking to randomize children and adults into different, COVID therapies and different biologics. So I'm sorry I've gone through that so quickly, but that was really all I had to say, other than thanking my colleagues at the Evelina, who some of their slides I have used. And obviously this is a huge team effort, and a huge amount of work has gone into looking after these children. So I'm happy to take questions if there are any, and I'll leave Sarah to manage that.
Thank you so much for such an interesting overview of a very scary and busy time. Does anyone have any questions? You can either pop your mic on, or if you post something in the chat, I will read out for everyone.
There's something in there. No, stunned silence. Maybe everybody's heard it so much that there isn't anything to question.
I mean, I guess my kind of a question for me would be that, obviously early on you had a very small number of patients who seemed to be having such a severe reaction to the virus. And I think it was really interesting to hear that at first, when it was kind of a couple of children from the same borough, it wasn't even necessarily clear that it was coronavirus related.
No.
And it could be, potentially other things.
Yeah. And certainly I didn't think about that, because they looked like toxic shock. First of all, they looked like a mixture of Kawasaki and toxic shock. But I mean, Kawasaki we hardly ever see in ICU, because it's managed very well by general pediatrics, and toxic shock we do see, and maybe 1 or 2 a month, but not 2, and certainly not 4 in 2 days. So it looked like there was something very strange going on, but I wasn't sure that, that there wasn't something in the community, but then it just, it very quickly twigged that it was just too much of a coincidence that this was something that looked like septic shock or like viral shock, and we were in the middle of a pandemic, so was it not related?
Absolutely. We've got a question here from Reaper who says, with schools now open, are you seeing a peak in PIMSTS?
No, not yet. I think what will happen is it followed in a kind of in about 6 weeks after the peak of the adult wave. So I think what will happen is we certainly will start seeing a peak, certainly a spike in this presentation in children in Northern England because of what's happening in Northern England. And I think the London second wave is coming. So I imagine we'll start seeing these children again in sort of 5 to 6 weeks' time. So be prepared.
And Geraldine says, amazing talk, thank you. Does the steroid treatment have to be methylpred, as I know in adults dexamethasone is also being used?
No, you can, it actually, I don't think there's any evidence yet that either methylpred or dex are better, and I think actually that is also the same in the adults. So whatever works, whatever is available, both of them work very well. I suppose it's just choosing the least worst of the steroids, and what we made the mistake at the very beginning because we'd had that child who died, and I think we were all traumatized by that, of putting the children on really high dose steroids and high dose aspirin. So we started off with methylpred at the very, very high pulse methylpred, 30 milligrams per kilogram. And we got lots and lots of side effects and lots of complications with really severe hypertension in these children as their hearts got better on the steroids, because of the inflammation and suppression, and their hearts got better again. They were able to mount incredible hypertensive responses to the point that actually, they were almost encephalopathic from the hypertension. So we had to reduce our steroids down, and we currently are on kind of, although they're still very significant steroid doses, they're kind of 10 milligrams per kilogram of methylpred now. And whereas our aspirin was 30 milligrams per kilogram to begin with, we've reduced it just down now to 5 to 10 milligrams per kilogram, depending on whether there's coronary involvement or not. So no, it doesn't have to be one or the other. I don't think there's evidence for that yet, and neither in adults.
Okay, and any other questions or comments from anyone? So
No, I think
Ruth,
just to speak.
yeah,
Sorry,
just says
carry
that
on.
children have positive swabs.
No, they don't. None of them had positive swabs. The majority in those first 16, by the time we wrote that Lancet letter, the Lancet letter got published, those first 15 out of 16 had positive antibodies, but not one of them had a positive swab in those first 16. And actually, I think out of our 150 or something that we've had in the Aberdeen, we've had 2 with positive swabs. This is not an acute viral infection. This is a post-infectious inflammatory response. And so they just have, evidence of previous asymptomatic usually. And from history, the children were, although their parents, I mean, we had, we had some with grandparents in the household who had died of coronavirus, but the children were almost to a child asymptomatic, patients really. And I think part of the reason, I mean, there's obviously lots of theories as to why children are not symptomatic, but the receptor for the pulmonary receptor for coronavirus is development. You need to have enough coronavirus respiratory receptors to actually have enough of a kind of viral load to make you sick. And obviously lung development is it happens throughout childhood. So interestingly, actually, in terms of this group of children, you don't see we saw very few young children. It was mainly the kind of older children who are reaching closer to lung maturity who actually got more severe disease. So I think the fact that children are, not innocent, bystanders, but they're not severely affected by the first disease is because they don't actually admit a huge amount of coronavirus. So it's just their very aggressive post-inflammatory response. And that post-inflammatory response, I have my own theory about that, but I think the reason why the Afro-Caribbean children are like that is because if you look at the Afro-Caribbean children's response to other diseases, like, for example, scarring, for example, that is a group that develops keloid. So they have this kind of predilection to have a kind of a really very, very, very aggressive immune response, because I personally think that in Africa, where I come from, South Africa, that is a survival tactic. If you can have a really aggressive response to an infection in Africa, you are a childhood survivor. So, it's a good thing in Africa. But when you come to England and you're not exposed to the same degree of childhood illness, then it may not be a good thing anymore to have that kind of aggressive immune response. So I think there's plausible kind of reason why you're seeing this this disease not affecting little children, and also why we're seeing this kind of ethnic predilection, although that hasn't been proven yet.
And Richie says, thank you. Any other questions, comments from anyone else?